Hello, everyone, and welcome to this talk that I call an evidence-informed approach to autism and its co-occurring conditions. I travel a lot around African countries and many other parts of the world, and a very common question that people ask me is, how should we approach diagnosis? How should we approach intervention? And how do we make sure that we also treat the co-occurring things that so often and almost always come with autism? So I thought over the next 45 minutes to an hour, we'd have a conversation about that and try to give you a bit of a framework to approach this important but slightly complicated topic. First, let me say hello to all of you from the beautiful city of Cape Town. And right here in the front of the screen in the middle, you can see the University of Cape Town, and right at the bottom, you will see the Division of Child and Adolescent Psychiatry, where we have a clinic, where we do research, and we do teaching and training. And greetings also from my research team. The Center for Autism Research in Africa is based in the Division of Child and Adolescent Psychiatry in Cape Town. And we do a range of research on screening and diagnostic tools, on interventions, on systems, on technology. That's not going to be the focus of our conversation today, but I thought I would say hello in any case on behalf of the team. The team is highly interdisciplinary, and it really just exemplifies that I don't think there will ever be a single professional group or a single agency who will be able to meet all the needs of autistic people and their families. And I hope the conversation today will also help you be very clear about that. So what I thought I'd do is just talk about three main themes. Firstly, what I call 7 pillars for comprehensive assessment of autism. Then go on to talk about 10 principles for intervention in autism, and then move on to talk a bit about the evidence base for conditions that co-occur with autism. And if you're interested in detail, in recent evidence, most of what I talk about here is captured in the recent Lancet Commission on the Future of Care and Clinical Research in Autism, of which I was one of the contributors. But you will be able to find this very, very detailed manuscript at the Lancet website, and it's freely available to anybody to use and to refer to. I would encourage you to go and look at that as a great reference source. One of the things we learned in that Lancet Commission was that everything in autism needs to be seen in the context of where the person with their autism lives. Because we know that autism is everywhere, but we also know that the globe is very different in terms of knowledge, resources, expertise, facilities, and so on. And so it means we need to start with a kind of a think about the autistic child and the autistic adult in the context where we are. And the highest, the broadest level of context we may think about, particularly nowadays, is the concept of neurodiversity. And there are many different ways in which people think about neurodiversity, but very simplistically, the concept of neurodiversity comes from the principle of biodiversity. And here we say and we celebrate that we are all different in our brain strengths and weaknesses, in the skills that we have. And that is what makes the world a beautiful place. And so there are people with many different abilities in terms of their social communication and behaviors and learning skills and patterns and knowledge base and so on. And that is a wonderful thing. But we also appreciate and we accept that some people, because of their profile of strengths and weaknesses, may actually have difficulties communicating, learning, participating in the world around them. And sometimes it is therefore helpful for them to receive a workup and sometimes get a diagnosis, and sometimes they may benefit from interventions or support to help them with their communication with their learning, with participation in society and in the world around them. So when we move from that neurodiversity big picture level and we land on thinking about autism and autism spectrum disorder, I'm going to use the word autism to mean autism spectrum disorder that we refer to in DSM-5 and in ICD-11. The most striking thing is the incredible heterogeneity and uniqueness of autism and of autistic people. So once again, we're not sitting with a single box. This figure that you see in front of you is the simple way that I try to explain to my medical students how we approach the diagnosis of autism. We have two main domains. One is the domain of social affect, and it has three subdomains that we're going to look for. The other is the stereotype and repetitive behavior domain, and that has four subdomains that we're going to look for. And we're going to consider somebody to have autism or be autistic if they have evidence in all three of these social affect domains and in two of the four stereotype and repetitive or repetitive and ritualistic behavior domains. But we'll come back to that in a minute. Once we have identified and we've made a judgment and thought about the autism, now we have to remember that almost all people have autism and co-occurring things. Many people have co-occurring physical health difficulties like seizures or seizure disorders, syndromes, gastrointestinal challenges. Many people with autism have other neurodevelopmental difficulties like intellectual disability or language disorders, for example. Many people will have mental health symptoms. So here's just a long list of mental health and neurodevelopmental symptoms: sleep, anxiety, mood, hyperactivity, attention difficulties, aggression, temper tantrums, and so on. And sometimes some of these are sufficient to meet criteria for a disorder, like a sleep disorder or an anxiety disorder or a depressive disorder or ADHD. And it is the combination of all these things that lead to the impact on our functioning now, on our functioning in school, our functioning in daily life, in adult life, and in work. And that's why the autism is sometimes the primary concern for us, but at other times, some of these co-occurring difficulties may actually be the primary thing that we want to do something about. Once we've identified my autism and other neurodevelopmental difficulties and mental health difficulties and physical health disorders, it's also important that we now need to consider that my caregivers may have mental and physical health and neurodevelopmental challenges of their own. And the research data suggests that we're more likely to have single parents or disrupted families when we have neurodevelopmental difficulties. We're more likely to live in poverty. We're very likely to have difficulty accessing support. And of course, our support needs will change over time. And with all these complexities, we're going to try and find support from either the health, the education, social care, or other sectors, depending on where we are in the world. And speaking of where we are in the world, we know that there's vast global diversity. And we know that even though 95% of autistic people live in low and middle income countries, we know that actually most of what we know about autism and the evidence base comes from high income contexts. So there are systems, settings, cultural and other things that we really need to bear in mind as we approach and think about assessment, diagnosis, and intervention or support for autistic children and their families. So having given that really big picture, high level introduction, let me now move to what I call 7 pillars of comprehensive assessment. And before I show them, a reminder that the detail with which we can follow these will be based and determined by where we are. But these are fundamental pillars, and so we should always try to think about all of them as we do a diagnostic workup. So here are my pillars. Number 1, we need to take a history. Number 2, we need to have observations. 3, we need to know about the intellectual level. 4, we need to understand the speech, language, and occupational skills and strengths and weaknesses of the person we're working with. 5, we need to understand the behavior and mental health profile. 6, of fundamental importance, we need to understand the family and their needs. And number 7, we need to think of appropriate medical investigations that may need to be done. Let me go into a little bit more detail for each of these. Starting with history, a reminder that autism is a behavioral syndrome, by which I mean it's diagnosed using things we see and hear. There are no lab tests, there are no specific things, and there are no, importantly, pathognomonic features. By that I mean there's no single thing of all the things that we're going to talk about in the next few minutes, that if we see it, we're going to say, aha, that means this child is autistic. Or if we don't see it, that we can say, aha, this means this person does not have autism. And it really therefore means that our diagnosis needs to depend on our judgment, our knowledge about autism. And it's not just about ticking boxes. It's about having a good enough understanding of the kinds of characteristics that might be specific or that might be indicative or suggestive of autism, rather than just a quick screener that we fill in. So my picture again, 3 domains on the social affect, or 3 subdomains on social affect, 4 on stereotype and repetitive behaviors. Let me now show what this looks like in words if we use the DSM-5 system. So on the social affect domain, we talk about persistent impairment in reciprocal social communication and social interaction across multiple contexts. And on the other side, we talk about restricted, repetitive patterns of behavior, interests, or activities. We want to see evidence of this emerging in the early childhood because autism is a neurodevelopmental condition. It's something to do with how the little brain is unfolding and growing up. And that's why we're looking for evidence in early childhood. And we want to see that it leads to impairment, to distress, to making life difficult for this person to participate in learning, in communication, and in the world around them. If we take another step further and look at the social affect domain, here are the 3 subdomains: socio-emotional reciprocity, non-verbal communicative behaviors used for social interaction, and developing and maintaining and understanding relationships. On the other side, we need to look for 2 of 4 of stereotyped or repetitive movements, use of objects, or speech, 3 different elements. Insistence on sameness. This is what we all think about when we think about autism, people wanting things to be done, having an inflexible adherence to routines, ritualized patterns of verbal or non-verbal behaviors. Number 3 is about very particular interests. And number 4 is about sensory hypo or hypersensitivities. As I say these words, I'm very mindful that they're written in quite medical language. And many autistic people don't like the very medical language. For our conversation today, I'm using the language in DSM-5 to help you understand and illustrate some of the typical things that we're looking for from a diagnostic point of view. So let's just look, I now move on this social affect side and the 3 examples. Let's just think about some of the examples we might actually look for in a young person or an adult. In that deficit in socio-emotional reciprocity, we may think about, does this person have an unusual approach to other people? And that could be about what we call the quality of their overtures, the way in which somebody approaches us. Do they do it in a way that feels natural and comfortable with eye gaze, with vocalizations? Or is it somebody who might suddenly appear to stand in front of us and not be interested, but not quite know how to initiate an interaction with us? Might they use our body as a tool, for example, to take our hand and put it on objects? as a way to communicate or as a way of wanting things? Is it difficult for them to have a to and fro conversation? We're all looking for the to and fro in the way we use our bodies, in the way we use our eye contact and nonverbal behaviors that we'll come on to in a minute. And so we're trying to see, is there a sense of to and fro? Does the other person build on the things that I add in my conversation? Do we perhaps see reduced sharing of interests or of emotions? So very typically, developing young children would bring us things to show us. They would get our attention. They would offer to share things. They would seek to share their enjoyment. They make us feel happy with them because they are happy. Do we see that in the person that we're working with? And how do they either initiate or respond to social interactions? Are they interested in other kids but don't know how to do it? Do they ignore other children when they approach them? Do they hide behind mum or dad when others are approaching or when they're in a social setting? These are all examples of the kinds of things we may look for in that socio-emotional reciprocity domain. In the second part, we're going to think about deficits in non-verbal communication used for social interaction. So it's not just do they have facial expressions or gestures, it's do they use their facial expressions and gestures to communicate. Children who have language disorders but not autism, let us know what they want. Young children, before they have words, let us know what they want through their faces, their bodies, their gestures, and so on. So here we're going to look for, is there some subtle differences in how verbal and non-verbal communication skills are integrated? Are there unusual facial expressions, for example? Are facial expressions perhaps not directed at other people, or just not subtle and nuanced enough? Do they use or understand gesture? So very typical gesture is to point at things that you're interested in. Mommy, look at the car. Daddy, look at the plane. Not because they want things, but just to indicate and get other people's attention to things of interest. Nodding, head shaking, there is a huge range of different kinds of gestures, and we often, in autistic young people, see difficulties with descriptive gestures to describe something like brushing your teeth or flying or swimming. And we see difficulties in emphatic gestures, the kind of emotional beats of daily communication, or maybe of emotional gestures, showing emotions through our hands and our body. In that third domain, we look at developing, maintaining, and understanding relationships. And again, there are many subtleties that we might look for. Is it perhaps difficult for somebody to adjust their behavior to different contexts? For example, not knowing how to behave in church or in school or in a library or on a bus, asking inappropriate questions at inappropriate times, or having inappropriate facial expressions, laughing in church, or clapping your hands at inappropriate times. Is it difficult to share in imaginative play with others, being able to imitate other people's action or join in group or social play? And sometimes we may not see an interest in other people, although I think it's important to say that most autistic people are interested in the people and the world around them. On that second domain, again, there's a huge range of possible things we may look for and try to elicit in our history taking or in our observations. That first domain of stereotyped or repetitive motor movements, use of objects, or speech, you can see the three elements, either hand and finger mannerism with finger flicking or complex mannerisms, or lining up of toys, opening up and closing things, repeated behaviors with materials, or the use of language in a repetitive way. For example, echolalia, saying the same thing over and over again, repeating things you've heard from others, or having unusual ways of speaking or of saying things. In the second domain of insistence on sameness, we try to see if we can identify somebody who has a very particular preference for things to be the same every day. And when they change, people typically become quite distressed. Small changes sometimes. Today I'm wearing glasses, tomorrow I'm not wearing glasses. Today my hair is like this, tomorrow my hair looks different. Today we're taking this route to school, tomorrow we take a different route. And these kind of small changes can be quite distressing or upsetting to people. And so we're going to look for this kind of insistence on sameness or wanting things to be the same. And there's a huge range of possibilities there. In the third domain, we're going to look for very specific interests. Many autistic people say, why does it have to be called highly restricted or fixated? I get really interested in specific things. And there are two main groups. One, things that could be a hobby to any of us, but the intensity is incredible. And an autistic person might know lots and lots of things about this thing. And it's not so much that they want to share it, but it is about the knowledge and collecting all the information. We also can have an intensity and focus to unusual objects or activities. Toilet seats, radiator points, plugs, cables, all sorts of things like that. And that might be something we will look for. And the fourth domain that was added in DSM-5 is that of sensory hyper or hyperreactivity. So that is being particularly interested in certain smells, touch, sound, etc., or being very sensitive to certain things. Here too, there's quite a big range. The kind of indifference to pain or temperature, there's one example, but people might be particularly interested in the sight, so that you might get prolonged in visual inspection, looking at things out of the corner of your eye very intensely. It could be liking touch or sensation. It might be certain smells that people like. And it could be the opposite as well, being very sensitive to certain smells, to certain food smells, to certain noises, to particular kinds of noises. And that is typically associated with an emotional response, either one of anxiety, often hands over ears or running away, or sometimes one of anger and aggression. And we'll come back to anger and aggression later. So you can see lots of things in the history and exactly the same in observation. We need to try to do observations in different settings, at home, school, and structured and unstructured activities. We're going to look to see how good is this child or person at attending, imitating, to and fro, the reciprocity, comprehending and understanding language, play, all those kinds of things. And there are many ways we can do it using standardized tools, like some of you have heard of the ADOS and other observational tools, but it's also something we can simply do by naturalistic observation or playing with children, as long as we know what we're looking for. The third element of our comprehensive assessment is to think about the overall intellectual ability. As you know, many people with autism have entirely normal intellectual ability, but we know that all autistic people are at risk of unusual learning profiles, of attentional difficulties, of some working memory or processing speed or other problems. And that's why it's helpful for us to consider what is this person's intellectual and neuropsychological profile, because it may tell us something about what's hard for them, or it may tell us about particular skills that they have that we can use. When we think about speech and language, autism has a fundamental element of communication. So we really need to think, what is the receptive and expressive language level of this person? Might they have any phonological difficulties with articulation, for example? Do they have language grammatical challenges? Or are there challenges mainly in the pragmatic use, in the social use of language, not understanding humor or expressions like pigs are flying or it's raining cats and dogs, for example? On the occupational side, Occupational therapy is particularly interested in functional ability and ability to participate in daily activities. So we're going to think about motor skills, sensory skills, other sorts of things like that. Not everyone may be able to have a speech and language assessment or an occupational therapy assessment, but by considering what all these elements are, we can already start to build up a picture of the needs of this child or of this person in front of us. Behavioral and mental health. Fundamental domain, there's significantly high rates of depression, anxiety, obsessive compulsive disorder, attention deficit hyperactivity disorder, and many other mental health conditions co-occurring with autism. And that's why it's important that we ask about it, we inquire about it, because for some people, these are the things that need priority treatment. I've already spoken about the family, and we'll come back to family later when we talk about interventions. We have to understand the family. What is their profile? Are there others with developmental disorders or autism? Might there be other psychopathologies like depression or anxiety? What other needs do they have in terms of their capacity to look after the family, financial stability and security, and all those other kinds of things that are so important in order to have the resources and the skill set to support a child who is autistic. And finally, the medical investigations. Knowing that there are many co-occurring medical, physical health conditions, we need to have a framework to think, what am I going to look for? And the recommendations are fairly pragmatic. We know that perhaps as many as 20% of autistic people, we can now find a known medical cause, typically a genetic cause. And that includes things like Fragile X or tuberous sclerosis or Rett or neurofibromatosis. Our clinical recommendation is to do a workup if you suspect something clinically. If you think somebody looks as though they may have a syndrome, looks as though they might have any of these that I've listed. So we don't broadly, as a blanket, recommend big genetic panels on everybody. We simply don't have the resources around the world, and the yield is still pretty low. We recommend imaging, ideally an MRI scan, if we can, of the brain, when a child has autism and intellectual disability and epilepsy, because that's when we want to exclude conditions like tuberous sclerosis complex, number one, and or other similar disorders. We recommend doing an EEG when it's clinically indicated. So once again, when it looks as though from the history or your observations that the child might have seizures or a seizure disorder. And remember, there are two main peaks where we might see seizure disorders. And we know the rates are high. The co-occurrence of seizures in autism is at least 30, or typically some people have different numbers, but let's call it 30%. Most happen in the first 2 years of life. So that's when we might see tuberous sclerosis or other genetic associated seizures starting. But then there's a second peak of the onset of epilepsy or seizures, and that's around 13 to 17 in early to middle adolescence. So that's very helpful to bear in mind if you're working with a teenager who is autistic and they suddenly start to present in an unusual way. They might lose skills. They might suddenly have things that could be seizures. We know that about a third of autistic people have regression, and some might use the term regressive subtype. And that normally happens around the age of 18 to 21 or 24 months. So we see a relatively normal, typical development, and then loss of those language skills or motor skills or other functional skills. And that's why what we're saying is if that's the pattern, we don't typically recommend a neurological workup. But if we see late regression, i.e. after 2 years of age, or if we suspect there might be clinical seizures going on, or if it's very fluctuating as a clinical cause, that's when we may do additional investigation. We're going to think about metabolic disorders, also very often associated with this kind of fluctuating course. We might think about mitochondrial disorders, a range of other fairly rare conditions when we have that clinical suspicion. So that's my very big picture approach to a diagnosis for autism. We're going to, once you've done your workup, you've done your evaluation, we're going to use one term, autism spectrum disorder. Most families nowadays prefer the term autism again. So they might say, let's call it autism. And we're going to describe it at different levels of severity. You will see in DSM, it talks about level 1, level 2, level 3. I don't find it very helpful to say somebody has autism level 1 or is autistic level 1 or 2 or 3. Number 1, it sounds a little bit too simplistic. Number 2, I don't like to give a number to anyone. Number 3, I think one can have very different levels of needs, even within and across those diagnostic domains. So the best is really just to describe. And so, for example, to use these specifiers, say, this person has autism with this level of need in their social communication or in their repetitive and stereotype behaviors, with or without intellectual disability, with or without a language impairment, with or without tuberous sclerosis or neurofibromatosis, with or without ADHD or something else, with or without catatonia. So that is how we're going to approach the diagnostic label if families are happy and keen to seek a diagnostic label. So let's now move to my principles for intervention. Again, this is not a detailed summary of all interventions for autism, but principles to approach intervention. Before I show the 10 principles, here's a question for you. And I want you, as you're watching this, to write down if you know what NDBI stands for. Because NDBI is nowadays the interventional approach that seems to have the strongest evidence base, and therefore the intervention approach that we want to try and make available to people around the globe. So I've written down what you think NDBI is. Here's my list of 10 things. I will read them out, and then we'll just give a little bit more detail about each of them. Number 1, we need a comprehensive assessment to guide comprehensive intervention. Number 2, there will never be a single intervention that will work for everyone. Number 3, we're going to accommodate. Number 4, we are also going to build skills through the core difficulties of autism. Number 5, we're going to look for and also treat the conditions that co-occur with autism. Number 6, we're going to be family focused. This theme around family is hopefully becoming clear to you. Number 7, we're going to use early intervention in early years and early identification and treatment throughout the lifespan. Number 8, we're going to understand the meaning of behaviors. Number 9, we're going to use evidence-based or evidence-informed interventions. We'll say something about that. And number 10, we are going to try to give everyone parent education and training, or parent caregiver education and training. And we're going to use, and here they are, naturalistic developmental behavioral interventions, or NDBI. So let's now go through them one at a time. You've seen my 7 principles for assessment, so you know every autistic person and every family will have a different profile of needs. And that's why we need to have the big picture to know, what does this family in front of you need? What does this autistic child or autistic adult need based on their overall biopsychosocial profile of needs? And then we're going to think and plan with them what their priorities are and what they want us to do next. It is so important to remember that there will never be a single intervention that will work for everyone because of this complexity, because of the diversity, because of the uniqueness of presentations. And that's why we're going to individualize. And we use some basic principles. So given the variability and the range, we typically are going to use approaches that combine behavioral, developmental, and educational strategies. So we're going to help expand social interaction, communication. We're going to help develop skills, and we're going to understand those behaviors and then try to reduce unwanted behaviors and enhance desired abilities. And all of these are about helping young people and adults, anyone with autism, improve their communication skills, improve their ability to learn, and improve their ability to participate as active participants in their daily lives. And just a very practical tip that I say to all doctors and families: if you're going to try an intervention and after 3 months you still don't see any change, even hints of change, maybe it's worth stopping and rethinking what you're actually using. We're going to remember that intervention needs to make change over time, and I'll come back to that too. Principle 3 is about saying we're going to accommodate, we're going to work around the autism. And there are many interventions, and in many countries, people are good at accommodating autism and autistic people. So if we argue that you might struggle to work in groups, you might struggle to communicate, we're going to say, well, let's use teach principles and help you work on your own and in a more structured way. Or if you can't communicate, we're going to give you picture exchange communication systems, or we're going to teach you a sign language, or we're going to give you alternative or augmentative communication systems to boost your communication skills. This is where we're going to think, of predictability, of structure, mind blindness, the nice word, just to not assume that people imagine that what we have in our minds, to be clear with our language. All these are accommodation principles. And they are important things to do and useful things to do. But we now know, and this has been a huge shift over the last 2 decades of autism research, that we can build skills through some of those core difficulties of autism. And let's just look at what some of those core difficulties are. I've already mentioned most of them. Communication skills. We can help people learn and develop their verbal and non-verbal skills. The turn-taking, social communication or social reciprocal skills. Joint attention, how to be together around a topic, and that is where we're going to help them learn in a joined way. Imitating, copying other people. We can help people develop peer relationships and play. We can help them with those repetitive and stereotypal sensory challenges that they might have, and so on. So there are many, many things that we can do that really target those core challenges of autism. This is just a slide from work by Jerry Dawson using one of those NDBI approaches called the Early Start Denver model, or ESTM, just to show the potential power if we use these interventions that go through the core of autism. In Jerry's study, where they worked with people in their communities over a period of 2 years, they found that the ESTM approach helped children in the intervention group have significant improvements in their language. And in fact, the majority of them ended up speaking. Not that speaking is always the goal. I think our primary goal in intervention is communication, not words. But in this study, almost all the children also started using words and sentences. And very interestingly, because this kind of intervention helps children with their learning, in this study, their Mullen, which is a measure of intellectual overall ability, went up significantly in the children who were in this intervention group. So that's a very powerful example that if we use the right targeted approaches, we can help children learn. And if we can help them learn from early on, it may have a profound impact on their ability to learn in school and to learn later in life as well. Principle 5 is about look for and also treat these co-occurring conditions. And they're both mental health and physical health co-occurring conditions. Here's a reminder of my complicated picture that looks a little bit scary of autism with co-occurring physical health, neurodevelopmental, and other mental health conditions. And it's helpful to remember that these typically come online at different times across the lifespan. So we may see this kind of intellectual or some of these physical things, seizure disorders you've already heard in the first few years of life sometimes, or adolescence. Some of the neurodevelopmental things may come on in the early years or preschool years. Anxiety and depression might start to come on here towards teenage years. So across the lifespan, different co-occurring conditions are more likely to appear. And that's why we can't just do an assessment at one point and then say, so there are no other co-occurring conditions. We have to keep monitoring for co-occurring conditions. And that's why we say look for and also treat co-occurring conditions. Principle number 6, and I put it right in the middle of the principles, also because I think the family should be right in the middle. We have really moved to the realization that families are fundamental as the holders and the supporters of their autistic children and autistic family members. And so everything we do in intervention has to be done with parents and caregivers and their communities as the key partners. And it's very clear that any intervention works best if it's embedded in the family and in the family context. In principle number 7, we're basically saying do early intervention in the early years and catch those emerging things and treat them as quickly as possible. So we try, we aim to start before the age of 3 when we can. That's typically what people think of as early intervention. But we also know that in many parts of the world, young people may not be identified before the age of 3. The principle, though, is as soon as we can. And then the principle for all these other dilemmas that come online over time is just to say, don't watch and wait. If you see something, jump on it and think, this is an autistic person who's at risk of these co-occurring things. Do we need to do something? Principle number 8 is about understanding the meaning of behaviors. And the word behavior is a strange word. I'm always curious that people seem to talk about it as though it's something very discrete and say, oh, this child presents with behaviors, or this child presents with difficult or challenging behaviors. And the most common question that people ask me about young people who are autistic is to say, what might be the best medication to prescribe this child for their difficult behaviors? And imagine in your own mind what my answer might be. But actually, the answer I give to people is to say, that's the wrong question to ask me. Because when a child presents with a difficult behavior, a behavior that challenges you, what they are doing is they are communicating something to you with their body. That's the simplest way to think about it. With my body, I'm letting you know something. And it's our jobs as families, as healthcare providers, as supporters, to try and work out what that might be. So if I ask you, think of 5 reasons why an autistic child might hit themselves. We have all seen and worked with and lived with children who might hit themselves or bang themselves or bite themselves. Just imagine for a minute, what might some of those reasons be? Perhaps write them down on a piece of paper or on your computer or something like that before I show you just a list that I had made up. So here are some of my list. Number 1, maybe a child is showing us through their body they are struggling to communicate with us. They're trying to let us know something and they don't have the words. Sometimes people might hit themselves or do things through repetitively, because it's soothing. It's kind of an anxiety-reducing strategy. Sometimes these things pop out because they're driven by impulsivity. Child who has a thought, has a feeling, and it's hard for them to stop it and keep it in. It's very common that some of these are driven by sensory stimuli, something that's too loud, something that's too smelly, something that doesn't look right, something that's unexpected. Sometimes behaviors that challenge are attention-seeking, but that's not always the case. And in fact, more often than not, it's not the case. It's more likely that a child, for example, who struggles with something might show with their body that they can't do it, and then they escape that demand that happens to them. And of course, very importantly, if I can't communicate to you that my ear is aching, that my tooth is aching, that my head is aching, or that something else is sore or uncomfortable, I might show that with my body and through my behavior as well. And as you can see, there's not one medication that's going to treat any or all of these. Each of them will have a different therapeutic or support approach. And that's what I mean by the need to understand the meaning or the function of the behavior that we're talking about. Principle 9 is we need to use evidence-based, or I might change it to evidence-informed interventions. And that's important because if we were to go onto Google or look in the literature, there will be lots and lots of possible things that people have said they've used for autism and that they claim to be helpful to autistic people and their families. And here's a long list of possible things on the screen. But the question we have to ask is, what is the actual evidence base for it? And then what is also the evidence base in our parts of the world, for example? And there is positive evidence. We know many of these early intensive behavioral interventions, or this EIBI, PECS, I mentioned the picture exchange communication systems, the TEACH approach, cognitive behavioral therapy, for example, for anxiety or depression or OCD, use of social stories in autism, the principles of applied behavioral analysis, using visual schedules, and of course, these naturalistic developmental behavioral interventions. There is evidence for these, that they do show gains and value and improvements to autistic people when we apply them correctly. We also know that some of the interventions that have been used over the years have evidence of harm. There's an approach called auditory integration training, where music and noises and sounds are played to people that has shown harm to people's hearing. There's something called facilitated communication, where people are meant to communicate through a facilitator, but more often than not, it's the facilitator's communication rather than the child's communication that actually comes through. Chelation has been used as an injection into the veins of people, claiming that it will bind heavy metals, and people have died from it. Dolphins, swimming with dolphins, dolphin therapy, a wonderful thing for anyone to do, but it's expensive. That's a risk, that's a harm. Dolphins have been harmed in the process. Children have struggled in the process. So there's a range of things that, if we know that they are harmful, we know that we should discourage people from using them, or really make sure that people avoid these. And then we also have to understand that there is little or a lack of evidence for many things that people are talking about in the world today. Cannabis oil, snake oil, stem cell therapies, even sensory integration therapy that's used very much. The evidence is limited or lacking, which means we just need to be very careful when we want to consider recommending it to our families. Principle number 10, where we're having an increasing evidence base, is parent education and training and naturalistic developmental behavioral interventions. And of course, you can get parent education trainings that uses NDBI principles too. So PET is really that fundamental step to give parents and caregivers appropriate, accurate, meaningful information. Some people call it psychoeducation, but I think parent education training is about more than psychoeducation. It's about more than knowledge. It's also about skills, strategies, coping, advocacy, self-care, and so on. And that really should be provided to everyone when there's a diagnosis of autism, to support people and empower people for their journey. And then naturalistic developmental behavioral interventions. I've said this is a group of interventions that now is the main therapeutic approach or intervention approach that we're recommending in the world. And just a very, very simplistic explanation of what NDBIs try to do. They are naturalistic because we try to use emotionally meaningful and daily life activities. And in those daily life activities, we're going to embed strategies to help children and people communicate better, learn better, and participate better. We're going to use naturalistic rewards, so things that are meaningful to a child. And we normally know things are meaningful because they're interested in it. And so when you see somebody do a naturalistic developmental behavioral intervention, it's going to look like a real naturalistic or natural way of engaging. But in that natural way, with a motivated and an interested child, we're going to embed these developmental principles. We all have different steps of all our development. And so here, we're going to say, this is where this child is at in their specific developmental steps. And I'm going to use that, my approach, to help them get to the next developmental step, whether it is in their social communication or whichever element. And you can see there's, in most NDBIs, there's a real focus on joint attention, coming together with a child and using imitation, often following the child or starting by following the child's lead to help social learning, to come together to become a helper for the child to learn, to communicate, and to participate. And we do use some behavioral strategies, modeling, shaping, chaining, understanding, breaking behaviors down into different bits, because we want to use the right sort of techniques to help a child learn in a successful way and gradually to make what they learn more and more complex. Another way, a very, again, visual way to think about it is we're really at the point where we are saying we want to move intervention and support away from the clinic, away from the therapy room, and into the family home, into the school, into the community, and do it during daily activities rather than during circumscribed half an hour of therapy sessions. So here's a beautiful picture from Amy Weatherby and Nola Chambers. We want to find meaningful daily activities that can help support that learning of communication, language, all sorts of other skills. For example, during meals and snack time, we all eat. During chores at home, during daily routines, toothbrushing, washing, having a bath. During play with people and play with toys and play with props and without things as well, which people might typically think of as kind of play-based. But there are many daily activities into which we can embed it by giving young people active roles and by then helping them learn to improve to enhance their communication, to enhance their learning. That's the spirit of naturalistic developmental behavioral interventions. So now you've seen the 10 principles for intervention, and I hope that gives you a big picture framework for it. So let's now just take a breath and pause for a minute and say, let's now switch to the evidence base for these co-occurring things. Because now we've talked about the autism itself or the autistic challenges. Let's now think about co-occurring conditions. So again, most of what I'm talking about in the evidence comes from the Lancet Commission that I mentioned to you, that's available, that's open access. So please feel free to go and look at that, to consult that. And let's go back to my drawing of autism and all its, or many of its co-occurring challenges. And here's another question to you all. For which of all these do we have an evidence-based licensed medication in autism? Because we're now going to switch to a slightly more pharmacological approach. I show you this list and you imagine for a minute, for what do we have evidence? In other words, where has there been randomized controlled trials in autism that have shown either treatment A better than placebo or treatment better than something else? And the answer is only licensed medications, medications in autism with a marketing authorization in autism is risperidone and aripiprazole, two atypical antipsychotics, both for irritability. And I'm going to ask you in your own mind, what is irritability? What makes you irritable? What might make your autistic child or family member or patient irritable? And you have to admit it's quite a mixed bag of things that could make people irritable. So even the construct for which there is a licensed medication in autism is a little bit problematic. So, two drugs, remember, and I will say something about them now, there are many adverse effects. Many people are really keen, therefore, to try and avoid these medications. Or many people might then say, might there be another medication that I could try for irritability or for challenges that perhaps doesn't have quite as much evidence? So, for example, clonidine, that people sometimes use in autism. If we just think about the side effects of risperidone, remember, increased appetite, tiredness, drooling, dizziness, weight gain, metabolic syndrome, a real problem. And even though aripiprazole, many people say, has a better side effect profile, it has many significant challenges too. And imagine having some of these adverse effects when you are struggling to communicate, when you are already struggling to learn, and when you're already struggling to participate in the world around you. So think about irritability and these medications. I spend more of my time taking young people off medications than starting them on them. Sleep disorders. Best evidence so far is that we really want to work on bedtime routines, that we really want to work on sleep hygiene. And, you know, most people are not very good at knowing what to do in terms of sleep hygiene. So that's really worth it. Reducing the total number of hours on media, median bedroom, being mindful of kind of sensory challenges of a child, other medical problems, particularly things like sleep apnea. And then sometimes, you know, once you've done your routine, your sleep hygiene, your media and things, sometimes it's helpful to use melatonin as an aid to reduce sleep latency. Sometimes people use antihistamines. It's a messy drug and the evidence is really not good. Clonidine is sometimes used, the sedating effect of it, to help people settle. And antipsychotics for sleep really should be a last resort medication. In this graph on the other side, you can see that the combination of behavioral and melatonin seems to show the best change from in young people to reduce sleep latency and to improve their ability to sleep. Anxiety disorders, very co-occurring with autism, first-line treatment, cognitive behavioral approaches. And you need to know how to do it in somebody with autism, particularly people with developmental challenges. But there are no studies of anxiety medications in autism, and so we use it based on the evidence for non-autism. And remember that if you're going to use SSRIs, selective serotonin reuptake inhibitors, you're always going to combine it with a talking or a behavioral approach, and you're more likely to see behavioral activation. So restlessness, anxiousness, pacing. You're more likely to see irritability, gastrointestinal symptoms. And those might be some of the fundamental things that you're already trying to reduce. Depressive disorders are exactly the same, commonly co-occurring. We're going to start with a talking treatment approach. And if we need to, we're going to add SSRIs and exactly the same challenges, behavioral activation, so restlessness, irritability, gastrointestinal challenges. ADHD, another very co-occurring condition with autism. And we know the evidence from many studies shows that it's when you have the combination of the two, outcomes are less good. And so there are many, many things that we have to do. And that might include the use of methylphenidate when the attention deficit hyperactivity symptoms are really significant. And we see that it might help. But autistic kids with ADHD are more likely to have adverse effects, appetite suppression, headaches, insomnia, irritability. Can you see how often irritability comes up as an adverse effect? So be careful that you don't then want to treat that irritability with yet another medication. Atomoxetine, a non-stimulant, might also help. That in turn has GI side effects, but it has a lower risk of kind of unmasking tics or of psychotic manifestations. Guanfacine, not available in all parts of the world. It's similar to clonidine, might also help. So guanfacine or clonidine can be helpful. People sometimes use, as I've said, the sedative effects, but it can make people fatigued and actually lethargic and not really have a good time. But it is a medication that as a second or a third line, we often do consider. And then we've already spoken about these behaviors that challenge, or I prefer to call them dysregulated behaviors. We need to understand the function of the behavior. That's where the principles of applied behavioral analysis, understanding that behavior, can be really helpful, because that will determine how we're going to approach it. Mood stabilizers in some parts of the world, people think that using anti-epilepsy medications when people don't have epilepsy in autism might help, but there's really no evidence that it'll reduce mood swings or behaviors that challenge. In fact, back to the principle, we need to understand what makes this child suddenly change in their mood. And we are often not careful and detailed enough to understand, to look, to observe, and to listen to families, who often are the best judges of what might be the triggers, the predictors, what happens before, during, and after. And that really is the biggest job we have to do. So please don't do mood stabilizers, because they can also increase irritability and are unlikely to be helpful. A final top-line comment about medications. Do everything you possibly can before you prescribe a medication. It's much easier to start medications than to stop them. So just recognize and share with families that the evidence base is very limited. It's only for irritability. And we're going to start as low as we can and go as slowly as we possibly can in our medication approaches. Please try to avoid polypharmacy. Please try to avoid prescribing more than one thing at the same time, and be very careful that and clear that you share with mum or dad and the family that we're going to try this for this specific thing. We're going to monitor this specific thing, and we're going to check if in a week or a month this specific thing does in fact benefit from or improve from this medication. Please monitor those side effects, because they can become major problems in themselves. If we have a young child who suddenly puts on a lot of weight, who suddenly doesn't want to eat or feed when they already have some sensory or avoidant restricted food intake behaviors. And just remember, medications might actually be the cause of some of these behavioral challenges that children might have. Life with autism is a journey. Our profile of needs changes over time. And therefore, we really need to have a long-term view, to have teams, to have people who can support families, who will understand that developmental disorders develop, that co-occurring things come online and unfold over time. So we really have to support families for a long-term journey. We know that there are certain points where things are likely to be more difficult during transitions. Home to preschool, preschool to primary, primary to secondary, secondary to adult life. When you're an adult between different jobs, but even the more subtle things, from one season to another, from holiday time to school time, from the week to the weekend. So just be mindful of all those kinds of needs. When there's a change in the child or the adult's behavior, they stop doing things they used to do, if they stop being interested in things they used to do, they seem to lose skills, please review, because it may be that there's a new emerging co-occurring condition that needs your attention. And one of the biggest lessons we've learned over the last decade, back to my theme of family, is families need knowledge and information and skills, but they also need the capacity to care. And caregiver well-being, the well-being of mums and dads and uncles and aunties and grannies and siblings, is absolutely fundamental to a family and a system and a community's ability to support and care for an autistic person. I really like this picture from the Lancet Commission that I mentioned to you earlier, which talks about societal responses to optimize outcome for autistic people. And the simple message here is we may do all the things possible to support an individual who is autistic and their family, to help them learn, communicate, participate, etc. But we also have to think, what can society at a big level do to become more enabling to autistic people and those with other developmental disabilities? And in this first picture, if we have a relatively low ceiling of opportunities, of encouragement, of wanting and helping people to be active participants in the world around them, the outcome, the adaptive functioning, might be relatively low. If we have higher recognition, support, and adaptations in our society, our opportunities may be better and our outcomes might be better. And if we can really try to achieve a world where we can make everyone, and there's similarities and differences and different abilities, be able to participate in whatever it is they want to participate in the world, then we are likely to have the highest level of outcome, the highest level of happiness, of positivity, of flourishing, not just of the autistic people, but also of their families and the people in their communities. So just a lesson and a reminder for all of us that we always think about an autistic person in their context, and that we always think about how we're going to support them based on their views, their preferences, their cultural desires, in the best possible way. Feel free to look at our website if you're interested to see what the kind of research is that we're doing. As I've said, this talk was not about my team's research, but I sincerely hope that this big picture talking about evidence-based approach to diagnosis, to intervention in autism, and to those co-occurring needs in people who live with autism was helpful to you, and will help you be able to support families who live in our communities, and who often need simple but powerful and clear evidence-informed strategies from us to help them thrive. Thank you very much.